Thank you for being here, and we're really excited for a new format for Grand Rounds
Deb.
today. It'll be a really awesome by our very own IMA beloved preceptors and faculty, who we're going to be doing a rapid fire journal club edition featuring GLP-1s and kind of non-traditional sense of utilizing them, and kind of also post-SIGM format as well. We're hoping to keep this going forward, and we're really excited that Dr. Fifer, Dr. Bryant, Dr. Weintraub, and Dr. Blum are here to do the inaugural edition of this. A little bit about our lovely speakers. So firstly, I have Dr. Cary Blum, who is a general internist at the Icahn School of Medicine at Mount Sinai with a clinical and academic focus on the prevention of atherosclerotic cardiovascular disease. His interests include diabetes management, lipidology, and chronic kidney disease. In addition to his research and clinical work, Dr. Blum serves as the Associate Program Director for the Mount Sinai Hospital Internal Medicine Residency Program, where he focuses on curriculum development and remediation. Next, we have Dr. Kelsey Bryant, who is a primary care physician and certified hypertension specialist at Internal Medicine Associates, otherwise known as RIMA. She has a master's degree in public health and pursued additional research training in general medicine and fellowship at Columbia, during which she earned a master's degree in epidemiology as well. Her clinical interests include cardiovascular disease prevention, chronic disease management, and improving quality, efficiency, and effectiveness of primary care. Next is Dr. Kenneth Fifer, who is an assistant professor in the Department of Medicine here at the Icahn School of Medicine at Mount Sinai. He's a practicing primary care physician and resident preceptor at IMA, and is a co-director of our IMA Diabetes Clinic. He is an associate program director in the Internal Medicine Residency Program as well, and assistant director of the primary care track, of which he is a former graduate. And last but not least, Dr. Jennifer Weintraub is an associate professor of medicine and medical education here at the Icahn School of Medicine at Mount Sinai. She serves as a primary care physician at IMA. She's an APD, as well as a director of the Internal Medicine Primary Care Track and faculty lead for education for the Mount Sinai Human Rights Program. Please join me in welcoming them today.
Thank you, Charlene, so much for those lovely introductions. And thank you to the department for having us today and to my co-presenters for letting me go first. So today we'll be discussing emerging evidence for the use of GLP-1 receptor agonists in the primary care setting. Our learning objectives are to contextualize the use of GLP-1 receptor agonists in primary care and to discuss the evidence supporting the use of those drugs in conditions other than diabetes and cardiovascular disease, and we have no disclosures. So we're going to start off with a little bit of fun. Instead of a mix-up question, we have a trivia question this morning. So modern weight loss and diabetes medications like semaglutide work by mimicking a gut hormone called GLP-1, glucagon-like peptide 1. But scientists didn't get the idea from a human. What surprisingly sluggish creature helped researchers discover a powerful GL1 analog called exendin-4? Take a moment to commit. Is it a stressed out sloth, a mildly offended platypus, a sunbathing Gila monster, an introverted iguana, or a caffeinated capybara? Commit. That's the answer, and if you still don't know, it is a Gila monster. Thank you to my colleague Kelsey for coming up with those lovely alliterative descriptions of the animals. So that brings me to a timeline also created by my colleague, Dr. Weintraub. So we wanted to go a little bit over the history of GLP-1 agonists before jumping into the newest data. So going back to the 1980s and 90s was when GLP was first identified from the intestine as a hormone that was important in metabolism and digestion. And later, as we discussed, identified from the Gila monster. And slowly it was developed into drug. Exenatide was the first medication released in this class in 2005. It was twice a day, injectable, approved for diabetes. And then 5 years later, we sort of started the march of increased potency and sort of decreased frequency of administration. So back when I was a wee first-year medical student, liraglutide came out, and then slowly but surely we got a bunch of new drugs. Dulaglutide was the first weekly injectable In 2014, this class was also approved by the FDA for weight management for the first time, in addition to just diabetes. And then 2017, Ozempic came out, and the rest is history. So we are going to go over 4 trials today. These are the trials and the references, just for your reference. I'm going to start with Surmount-OSA, which is tirzepatide for obstructive sleep apnea. So we'll start you off with a patient. This patient's actually one of my real patients. She's a 53-year-old woman with obesity and hypertension. She's made many attempts to lose weight with diet and exercise and is not interested in surgical options for weight loss. You know that Medicare does not cover medications for obesity, and the patient does not have diabetes or a history of ASCVD, so you prescribe metformin off-label for weight loss. 6 months later, the patient returns saying that metformin is causing GI upset and her weight is stable. Does that sound familiar to anyone? So you remember that you recently heard that Medicare now covers tirzepatide for sleep apnea in patients with obesity. So you calculate a stop-bang score of 6 out of 8, indicating a pretest probability of severe OSA of greater than 50%. You order the sleep-home apnea test, and lo and behold, when the report returns, it shows severe OSA with an AHI of 44. So you've now gained potential access to medication. You prescribe the Zepbound, and you make sure to use the OSA diagnosis code as well as obesity in the prior authorization. So why are we not allowed to use medications purely for obesity? Back in the simple times in 2003, when the Medicare Prescription Drug and Improvement and Modernization Act was passed, also known as Medicare Part D, this was just one of the stipulations of the legislation. It has remained this way ever since. However, more recently, there's been the recognition that in addition to not just obesity, but sort of treating obesity-related comorbidities may be fair game, and indeed, that's the way things have gone. And this paper that I'm about to describe sort of backs up the evidence supporting the use of tirzepatide in severe OSA among patients with diabetes. So ask the question, in patients with moderate to severe OSA, defined as AHI greater than 15 and obesity, but without diabetes, does tirzepatide 10 or 15 milligrams result in a greater reduction in AHI than placebo? This paper was published about 1 year ago in New England Journal of Medicine. Just a little bit of background about the medication that was used. Tirzepatide was the first dual incretin agonist. It's called that because it has activity on both the GLP-1 receptor as well as the GIP receptor. It's this little diagram here, or cartoon on the right side of the screen. You can see the various effects that those hormones have on their target organs, which include improving insulin sensitivity, increasing insulin secretion, decreasing glucagon secretion, slowing gastric emptying, decreasing appetite. And then on the GIP side, many of those similar activities. So we have a very potent way of reducing appetite and lowering weight in a variety of different mechanisms. It's injected in doses of up to 15 milligrams, and it's now FDA approved for both diabetes and weight loss under 2 different brand names. A little bit of background on weight and OSA. This is not new as opposed to tirzepatide. We've known for a very long time that the 2 conditions are related, and weight loss has been known to be effective treatment for OSA for decades. It's thought to help by decreasing soft tissue in the upper airway, which reduces tongue fat and then helps the airway become more patent at night. So a little bit more about the trial. The participants had to have an apnea-hypopnea index of at least 15, which is the definition of moderate or severe OSA. They had to have a BMI of at least 30, so obese, and no diabetes. This was split up into 2 trials, actually, 2 separate randomized controlled trials with the same design. The first one was among patients who were not using PAP therapies and no CPAP at home. Second trial, yes, CPAP at home for at least 3 months prior to starting. It was a phase 3 randomized double-blind placebo-controlled trial that lasted 52 weeks and recruited patients from 60 sites across 9 countries. Just a little bit more about the outcomes. of interest in OSA. So there's the good old apnea-hypopnea index, which is simply the number of times per hour that the patient's ventilation is reduced enough to result in an O2 sat dip. This is a long established and long studied metric, but it's a bit flawed in that it only is a count and it doesn't really account for the severity or the depth of the O2 desaturation. So there are other metrics as well that have been generated and validated, including the sleep apnea specific hypoxia burden. The Epworth Sleepiness Scale and other survey instruments are also often used as outcomes in OSA trials, which get a little bit more to patient-related outcomes and improvement in quality of life and quality of sleep. And then last but not least, cardiovascular outcomes, because there's a well-known connection between OSA and cardiovascular disease. In this study, the AHI was the primary outcome, but there were several secondary outcomes as well, including the sleep apnea specific hypoxia burden and some patient questionnaires and cardiovascular data as well. This is table one. The patients that were recruited were largely in their 40s or 50s on average. Trial one was a bit younger than trial two. Most of the patients were male, a little bit more male in trial one than trial two. I'm sorry, I take that back, opposite. There were more men in trial two. It was about 2/3 Caucasian and a pretty good representation from Asian and Hispanic populations with fewer African American and Black patients enrolled. And the average BMI was in the high 30s. And the AHI was very high. So it was in the high 40s to low 50s on average, depending on the group. So that's very, very severe OSA. And these are the results. So on the top, or I'm sorry, on the left side, you've got trial one. So those are the patients without CPAP. On the right, you've got the patients with CPAP. And the top, you can see the change in AHI over the 52 weeks, and that the tirzepatide group AHI dropped by 27 points. There was a significant reduction in the placebo group, but much less, and very similar results seen in trial two. In terms of weight reduction, which is on the bottom of the screen, also very effective. You can see that the tirzepatide group lost on average 18% of their body weight in trial one and 20% in trial two. There was also a significant weight loss in the placebo group, but much less. Some other outcomes of interest. So I highlighted a few that I wanted to point out here, just that this secondary outcome basically describes patients with essentially remission of their OSA in that their AHI has dipped to either not in the range of OSA or very mild, and they have an Epworth Sleepiness Scale of very low. Patients who received tirzepatide were about 3 times more likely to experience that outcome than those in the placebo group. In addition, blood pressures dropped by about 10 points-ish, and pretty impressive considering tirzepatide's not a blood pressure medication, works about just as well as they do. And then in addition, the sleep apnea specific hypoxia burden was significantly reduced. So it's not just sort of the AHI, which I sort of described as a potentially flawed metric, but all the other metrics that we care about as well. Patients also reported an improvement in their sleep quality, although the sort of magnitude of that was less impressive, only an improvement of about 4 points on a scale of 100. Adverse events were, as you imagine, very high rate in this medication because of GI stuff. But as you can see, the placebo group had just pretty much just as high rate of adverse events. Serious adverse events were rare and just about as common in the placebo and the control and the treatment group. This was a very convincing study, but it wasn't perfect. I just want to point out some of the limitations. So the OSA in the patients that were enrolled was very severe. And so while we can generalize this to patients with very severe OSA, it may not necessarily be as effective of a strategy in patients with mild or moderate. In addition, the BMIs were rather high. So I think it's a little bit more of a question mark about sort of how effective it is in somebody with a BMI of closer to 30. Already kind of described how AHI is not a perfect outcome. But they did have very robust secondary outcomes with impressive results. It was only 52 weeks, and it was industry sponsored, so take it with a grain of salt. And there was no comparison of tirzepatide with PAP therapy, which for me as a primary care doctor might be a very interesting thing to look at. My patients sort of with a new diagnosis want to know which one is more effective. We're not really able to say that based on this study. So that is where I will end. Thank you very much. And next up is Kelsey Bryant.
All right. Thank you all again for having us. Nice to see some of my residents in the audience. Hey guys, thanks for coming. All right, so we are going to move on to another organ. So I'm going to be presenting the Synergy-NASH trial, which is looking at tirzepatide for metabolic dysfunction-associated steatohepatitis. If you ask me, there's nothing scarier than decompensated cirrhosis. So I'm personally very interested in preventing it. Liver really freaks me out. So I'm glad to see that there are potentially things to prevent the progression of liver disease. A quick note on terminology. So you might see things flip-flop, so to speak. So we used to call this condition NAFLD and NASH, and now it is switched to MASLD and MASH. So this change was in 2023. So you just might see in some of the literature, especially for trials that were started during that period or maybe submitted for publication, the terminology might switch, but it's the same thing. I will mostly use MASLD and MASH. So we'll start with the case, and this is the same patient that Cary started us out with. So you saw this patient, you evaluated her for sleep apnea, and you also decide to screen for MASLD because you recently learned that the global prevalence is increasing and it can be as high as 40% in some parts of the world, including here. You obtained transaminases and platelets and calculated a FIB-4 score, and you find out our patient has a score of 2.1. This is not a talk about screening, but I will tell you if you don't know that that is a score that would send you on to FibroScan your patient. And this returns with the result of S3 and F2, which indicates severe steatosis and moderate fibrosis. So you think to yourself, this is a problem. And you recall there's a drug called resmetirom that was recently FDA approved for patients with MASH and moderate to severe fibrosis. But then you also think, maybe there's another medication that might work as well. And in this case, the patient's not really interested in starting two drugs, and they ask if tirzepatide might be an option to help their liver. So thankfully, there's some data to help us understand this. So the question for this trial here is among patients with MASH and moderate to severe fibrosis, so F2, F3 on that FibroScan, can tirzepatide improve MASH without worsening of fibrosis? And if so, what is the appropriate dose? So this was published a year ago in 2 days or 3 days, just last summer. So the background here is that the benefits of weight loss in MASH or MASLD are really well described. This is not news. Similar to sleep apnea, we've known that this can help, but we also know that weight loss is really hard. Especially in folks who are able to achieve greater than 10%, we are able to see some regression in MASH and MASLD, especially on imaging. So phase 2 trials of GLP-1 agonists have shown resolution of MASH, but there's uncertain outcomes on fibrosis. And then when we think about liver disease and the progression of liver disease, fibrosis is really what drives outcomes. And so sure, you can see a FibroScan look better, or you can see other metrics look better, but what does that really mean for the outcomes for our patients? So we don't really know yet. This is a phase 2 multi-center double-blind randomized placebo-controlled trial, which is like really kind of all the stuff you want to be able to evaluate a drug. 130 sites across 10 countries, and it was industry sponsored. Patients that were included were 18 to 80, so really big range, BMI between 27 and 50 with biopsy-proven MASH and fibrosis. And they also had a NAFLD activity score, which is determined based on histology findings greater than 4 on a scale of 0 to 8. Patients that were excluded had liver disease from another cause, existing cirrhosis, evidence of hepatic decompensation, excessive alcohol consumption, or uncontrolled diabetes. So it's important to note that some of these patients had diabetes, but their threshold for exclusion was an A1C of greater than 9.5% or a use of GLP-1 already. This is a summarized version of Table 1, and so I just want to walk you through a couple of the highlights. So this was randomized into different study groups. This is a total population. So a few things to note. So there were 190 patients, which is not huge, but again, we're using histologic diagnoses. So there's a pretty intensive commitment for the patient. Average age was around 54, 57% female. Not the most diverse, 86% white and 36% identified as Hispanic or Latino. The average BMI was 36.1. And I just want to point out that over half of the patients had a diagnosis of type 2 diabetes, though their average A1C was 6.5. Uh-oh. Okay. So this is my creation of some of the results in the randomization to kind of summarize it in a hopefully more visually appealing way. So again, here we've got 190 patients. They were randomized to placebo, tirzepatide 5 milligrams, 10 milligrams, and 15 milligrams. And of note, these patients weren't just started all of a sudden on these doses. They followed a typical titration plan where they start at 2.5 and go up, and then they would just max out on whatever dose they were randomized to. The primary endpoint was percentage of patients who met criteria for resolution of MASH, which is actually looking at those biopsies, looking for a reduction in that lobular ballooning, and also serologic findings with no worsening of fibrosis after 52 weeks. So in the placebo group, there was 10% resolution, 44% in the 5 milligram group, 56% in the 10 milligram group, and 62% in the 15 milligram group. So we see the primary endpoint increasing in a dose-dependent manner, and that's higher for the placebo group across all groups. So next, if this works correctly with my animation, this is the percentage of patients who met criteria for resolution of MASH with no worsening of fibrosis. So, oh, sorry, that didn't work, but now it's working. Okay, so now the secondary endpoint is the percentage of patients who had improvement with at least one stage of fibrosis. So this is really interesting. So 30% of patients in the placebo group actually had an improvement in their fibrosis, 55% in the 5 milligram group, 51% in the 10 milligram group, and 51% in the 15 milligram group. So this, interestingly, actually does not follow a dose-dependent fashion in resolution of fibrosis by at least one stage. And this figure is how the authors presented that same information without the animations, but you can see here, so this first panel here, A, is resolution of MASH with no worsening of fibrosis, and tirzepatide 5 milligrams, 10 milligrams, and 15 milligrams improve in that dose-dependent fashion compared to that 10% in placebo. And then interestingly here, when we talk about the decrease in fibrosis, which is really what drives outcomes at the end of the day without worsening in MASH, we don't see a huge difference among dose-dependent groups, and we do see some in the placebo group. Adverse events, very similar to what was shown in the Surmount-OSA trial. It's mostly GI side effects, mostly diarrhea, constipation, nausea, reflux. 92% of people across the drug group complained of adverse effects versus 83% placebo. So high across the board, definitely higher in the drug group. And then a few notes as we conclude this trial. So 52 weeks, all 3 doses of tirzepatide were superior to placebo with respect to MASH resolution. And this happened in a dose-dependent fashion. The authors had some interesting commentary about the fibrosis findings, which I also found interesting. So the decrease in fibrosis was also superior to placebo, but it wasn't dose dependent. So as you saw, it was actually highest in that 5 milligram group. But there are a lot of things that could potentially explain this. So one, this is a relatively short trial with a relatively small sample size. And the authors postulated that perhaps around 50% regression is really just the ceiling effect of fibrosis. And that really is to be told in the future. So that brings me to a few limitations that I've already mentioned: small sample size, mostly white patients. And most importantly, there are actually no clinical outcomes in this trial. This is a histologic trial looking at changes in the liver tissue specifically. And so eventually, hopefully, we'll have clinical outcomes that mirror some of these findings. But a whole lot of other things in the patient's labs showed improvement. So transaminases, liver fat content, other serologic markers all improved. So it stands to reason that there's likely going to be a clinical benefit in the long run, but we really don't know yet. So we'll let Jen take it over with obesity and knee osteoarthritis, and I thank you for your attention.
Good morning. Thanks for having us. So our case continues. Our patient was so thrilled with the improvement in her sleep apnea and liver function, not to mention weight loss, due to the tirzepatide that she refers her sister to us for primary care, which is the biggest compliment I think you can give someone in primary care. Her sister is a 51-year-old woman with a history of obesity, BMI 38, and a long history of knee osteoarthritis that was confirmed on recent x-rays. She experiences pain when she walks as well as when she climbs stairs, and she stands for long periods of time. She notes knee stiffness for 20 minutes in the morning, and most importantly, her ability to function is affected. She has difficulty walking, getting out of bed, putting on and taking off her socks, housekeeping, and even sitting and standing. She's tried NSAIDs, acetaminophen, physical therapy, and has tried to lose weight without lasting success. And she asks, "Doc, can I take that magical injection you gave my sister?" So this leads us to our next study. This is the STEP 9 trial. So looking at in patients with obesity and moderate knee-OA with at least moderate pain, does weekly semaglutide result in improved weight loss and knee-OA pain as compared to placebo? And this was published in the New England Journal in October of 2024. So quick background, we know that obesity is a major risk factor for the development and progression of knee-OA. We also know that weight loss helps. So this study was really designed to look at, can semaglutide help? This was a randomized, double-blind, placebo-controlled trial. It took place in 61 sites across 11 countries, and very similar to a lot of the GLP-1 studies, it was industry funded. And as we talk about in Rapid Fire Journal Club, that doesn't mean that the validity is nullified, but it is notable. And this is a little picture of knee-OA. So who was included? So this was a study for patients who were 18 years and up. They needed to have clinical and radiologic diagnosis of moderate knee-OA. For clinical, they define that as having knee pain plus 3 or more of the following: age greater than 50, morning joint stiffness lasting for less than 30 minutes, crepitus, bony tenderness, bony enlargement with no palpable warmth. And the radiologic diagnosis was obviously on X-ray or imaging. And then they also included patients who had moderate to severe pain based on the WOMAC score, which I'll introduce in a minute. The WOMAC score, yeah, like I said, I'll show you in a sec. For exclusion, they had a long list of exclusion criteria. The most notable were a history of knee replacement, patients who had had arthroscopy or knee injections within the past 3 months, and any evidence of active joint disease besides osteoarthritis. Okay, and then primary outcomes, they looked at percent change in body weight. They also looked at the change in WOMAC pain score. And then for secondary outcomes, there were a whole slew. Most notably, they looked at the percentage of patients that had a body weight reduction of either more than 5% or more than 10%. They looked at the change in WOMAC physical function score, and also the change in another physical function score called the SF-36. So just to kind of talk about what that is, on the right, the WOMAC stands for Western Ontario McMaster's University Osteoarthritis Index. It's a pretty well-validated tool to measure osteoarthritis under 3 different areas. So it looks at pain, and they look at pain while doing certain activities, so walking, sitting, stairs, etc. Patients can rate their stiffness in the morning and the evening. And it also, I think, one of the more clinically relevant things it measures is physical function. And so it's asking patients to rate difficulty when doing a whole variety of activities. I gave a few examples here, like climbing stairs, rising from sitting, standing. This total score is out of 100, with higher scores meaning more severe symptoms. The study protocol took place up to 68 weeks. And so like most of the other GLP-1 studies, the first 1 to 16 weeks was meant for dose escalation. So patients were started at semaglutide 0.24 and titrated up to the max dose. About 90% of the patients in this study were able to get to 2.4, which was the maximum dose for semaglutide. They also included diet and activity counseling every 8 to 16 weeks, and surveys were given to all of the patients in the study every 8 to 16 weeks as well. So who was in the study? This was our table 1. Not a full table 1, but just to point out, this was predominantly, there were much more women in the study. It was about 81% female. We also know that arthritis is more common in women than men, but still very heavily skewed towards women. This was a population that had overall very high BMIs. Somewhere around 40% of patients in this study had a BMI greater than 40. They also had overall very high WOMAC pain scores. So average pain score was around 70 on this 0 to 100 scale. Okay. And so what did the study show? So as expected, they had the semaglutide group had a statistically significant decrease in body weight. The semaglutide group lost about 13% of their body weight on average compared to the placebo group, which did decently well, I think -3%, with some diet and exercise counseling. They also had a statistically significant improvement in their WOMAC pain score. And so there's kind of mixed data in the literature, but somewhere around a 10 to 20% decrease is considered clinically significant, or at least minimally significant for the WOMAC pain score. So we're really looking for bigger drops as a clinically significant outcome. So the placebo group had an improvement in pain by less than 27.4 points compared to the semaglutide group, which improved by 41.7 points. So much bigger. And there is a correlation, obviously, with weight loss and improvement in pain score. They also kind of showed us the results in a few different ways. So this was patients who had a reduction in their WOMAC pain score greater than 30, showing that more patients in the semaglutide group had a greater improvement. And then when looking at a reduction in pain score from 50 points, also statistically significant higher decrease in the semaglutide group. One of the other secondary outcomes they looked at was the use of non-prescribed medications for pain. And so thinking about looking at acetaminophen and patients getting NSAIDs. And as you can see here, so the orange is the semaglutide group and the blue is the placebo group. The patients in the semaglutide group had a higher rate of acetaminophen use at the beginning of the study, but by the end had kind of come down to lower. So they did have a greater decrease in the amount of Tylenol that they were requiring. And then same, there was also a trend towards requiring less NSAIDs, although this was also seen in the placebo group as well. So a few things to note about this study. So overall, adverse rates were quite low in both groups and not statistically significant. Compared to the studies that Kelsey and Cary presented, only 2.2% of the semaglutide group was noted to have GI symptoms, which seems much lower than expected, and none in the placebo group. And then a few limitations. So there was no long-term data on structural joint outcomes. So this was really a study looking at clinical outcomes, which is what we care about a lot for our patients. But they didn't follow up any x-rays or really look to see if any structural change happened in the joints. We know from other studies that the GLP-1 seem to have some anti-inflammatory properties and other things. So is there some type of joint change happening? They did not look at adherence to diet and physical activity recommendations. And I think the other thing to note is there was no measurement after the end of the treatment period. So after the period of the study, is this a lasting, there was no measurement to see if the clinical improvement in joint OA symptoms lasted beyond the time of the study. Did the groups come back together after treatment was finished? One might think possibly, right? The data we know from our weight loss medication shows that generally patients start to gain weight when the treatment is stopped, but this was not looked at either. So I think overall, big take home for this study is in patients with knee osteoarthritis, treatment with semaglutide was superior to placebo or standard care in terms of looking at clinical outcomes of OA, specifically with pain and also physical functioning. And I will hand it over to Kenny to talk about our last trial.
Great, thanks, Jen. Good morning, everyone. So we're going to talk about our last trial now and move on to our last organ of the day, which is the kidneys. So to extend our case, unfortunately, our patient's insurance does not cover semaglutide for obesity or arthritis, a familiar story. So she returns to care a few years later with a new diagnosis now of diabetes. Her A1C is now 8.7%, and basic metabolic panel shows her GFR to be reduced at 55. Labs also show she has an increased urine albumin creatinine ratio at 356, overall consistent with chronic kidney disease stage 3A, A3. So, one thing to kind of wonder about is, could this have progression to diabetes and CKD been prevented if she started semaglutide a few years ago? We don't know the answer to that. But now, given the diagnosis of diabetes, GLP-1s will now be covered by her insurance, and so we can utilize them here. So the question for this trial is, in patients with diabetes and chronic kidney disease, does weekly semaglutide decrease the rates of progression of renal disease? And this came out also about a year ago. So a little bit of background, again, as we're all aware, ACE inhibitors, angiotensin receptor blockers, and SGLT2 inhibitors in patients with type 2 diabetes have strong data that they improve kidney outcomes. Semaglutide has been sort of well established in patients with type 2 diabetes to improve cardiovascular outcomes. So now the question is, does semaglutide also improve kidney outcomes in patients with type 2 diabetes? So this was a large multi-center, multinational clinical trial over 387 sites, 28 countries in total. About 3,500 adults with type 2 diabetes and high-risk chronic kidney disease, as defined below, were included in the trial. And importantly, they were also receiving a stable, maximally tolerated dose of an ACE inhibitor or angiotensin receptor blocker, because that was sort of the standard of care, of course, for managing chronic kidney disease and type 2 diabetes at the time the trial was conducted. So the trial was randomized, double-blinded in a 1-to-1 fashion, semaglutide 1 milligram versus placebo. They sort of, this is the dose escalation schedule for semaglutide, started at the low dose to the medium dose, and ultimately with a goal of the 1 milligram dose as the maximum for this trial. And semaglutide could be reduced or maintained at lower doses than 1 milligram if the higher doses were not tolerated. So this is the primary outcome. So this is a composite of major kidney disease events, or MAKE. And it consists of several factors. So onset of renal failure, initiation of long-term renal replacement therapy, kidney transplantation, reduction of eGFR to less than 15, a greater than 50% reduction in eGFR from baseline, death from renal-related causes, and importantly, they included here death from cardiovascular causes. So death from cardiovascular causes is not usually included in the major adverse kidney event composite. It has been included in some more recent clinical trials. But very important to note for this study, because as we just mentioned, semaglutide we know is well established to reduce cardiovascular events in patients with diabetes without kidney disease. This is the sort of selected patient characteristics. The average age for patients in the trial was around 66, with a pretty broad geographic spread. So a couple things important to note here. So patients using SGLT2 inhibitors. So only 15% of patients randomized in the trial were already on SGLT2 inhibitors. If this trial was conducted now in 2025, I would expect that number to be much higher. But at the time this trial was conducted, it wasn't as much part of the standard of care as we're accustomed to now. But that's a big caveat here. About 95% of patients were on that sort of maximally stable tolerated ACE inhibitor or angiotensin receptor blocker. The remaining 5%, couldn't tolerate it because of hyperkalemia or other factors. So the median follow-up for the study was 3.4 years, and the trial was halted early due to efficacy. So looking at that primary outcome, that composite of major kidney disease events, that occurred in 18% of the semaglutide group versus 23% of the placebo group. So that's a hazard ratio of 0.76, or a number needed to treat of 22. So pretty good. But looking sort of at the subgroups for those renal outcomes, it seems like the primary outcome was driven primarily by two components. First, a improvement in the rates of reduction of 50% in baseline eGFR. So there was fewer patients in the semaglutide group who had greater 50% reduction in eGFR. And then also you'll see the death from cardiovascular causes was a pretty significant driver of this primary outcome, and less so of the other sort of three dedicated kidney outcomes. Looking at a few secondary outcomes, so in terms of major adverse cardiovascular events, there were significantly fewer in the semaglutide group versus placebo, with a number needed to treat of 45. As we might expect from prior data. All-cause mortality was also significantly decreased, with the number needed to treat of 33. So looking at sort of some subgroup analysis, I thought this was really interesting. So looking at patients on SGLT2 inhibitors prior to being randomized in the trial. So again, only 15% of patients were already on it, were on SGLT2 inhibitors. So for patients not on SGLT2 inhibitors, we saw a statistically significant improvement in the primary outcome towards the semaglutide group. But in those patients on SGLT2 inhibitors, that improvement was not evident. That may be due to power, or it may be due to lack of effect with patients already on those drugs. We're not sure. Looking at adverse effects, there were some more adverse effects in the semaglutide group, though not drastically. And again, those are the typical GI side effects that we've already talked about. There are fewer cardiovascular events in the semaglutide group, again, as we would expect. Why would GLP-1 agonists in the first place be potentially beneficial to kidney health? So there are a few sort of theories. One is sort of reduction in renal and cardiovascular risk factors themselves, obesity and glycemic control. It's also thought that GLP-1s reduce renal cellular expression of pro-inflammatory and pro-fibrotic factors, or is it also partially a natriuretic effect as well? So, a few limitations, which I've already kind of discussed a little bit. So again, the primary outcome included cardiovascular events, with the sort of idea that patients with diabetes and chronic kidney disease are at, particularly high risk. So I think that's the argument to include cardiovascular events in there, though I would argue that's a big caveat here and limitation. And again, only 15% of patients were already on SGLT2 inhibitors, which has been pretty established now as standard of care for patients with diabetes and chronic kidney disease. 90% of participants identified as white or Asian, while only 10% of patients identified as Black or other, so may or may not be, representative of the patient populations for whom we care. So in the future, we sort of need to sort of decide or investigate the optimal priority and combination of medical therapies to manage chronic kidney disease in patients with type 2 diabetes. And so that takes us, out of the study and back to our Gila monster. So just to kind of review some key takeaways from the studies we've discussed, tirzepatide reduces the apnea-hypopnea index in patients with obesity and moderate to severe OSA. Tirzepatide has also been shown to improve MASH without worsening of fibrosis. Semaglutide improves knee pain and function in patients with obesity and knee osteoarthritis. And semaglutide also has been shown to decrease rates of progression of chronic kidney disease in patients with type 2 diabetes, at least those not already on SGLT2 inhibitors. So thinking about, there's now like more and more GLP-1 data. And so just kind of trying to like reset the stage of where we are. So we have sort of solid data of that GLP-1 agonists are extremely effective for the management of type 2 diabetes. There's now significant data showing improvement in cardiovascular outcomes, maybe even HFpEF, cardiovascular death, certainly weight loss, diabetic kidney disease perhaps. And, where is this sort of going in the future? We talked today about metabolic associated liver disease. There's also kind of like ongoing talk and investigations into possible beneficial effects on Parkinson's disease, Alzheimer's disease, peripheral artery disease. So, we'll see. And that's it. Thank you.
So thank you for our wonderful four speakers. We have about 10 minutes for questions. So yes.
Seems like, thank you guys. It's helpful and good. Curious, moving forward from here, it seems like a lot of the drivers for the problems that GLP-1s cure are related to diabetes and or but there are a lot of other secondary things that are curious from the insurance approval perspective. You guys see the push for like approval more so like moving into the space of obesity for patients with Medicare and Medicaid, or is it going to be a case that we need to get approval for these specific indications that GLP-1s help with? Can you repeat the question?
So yeah, sure. So the question was, as these drugs are sort of more utilized, there's been sort of some insurance resistance to cover drugs particularly for obesity, particularly with Medicare and Medicaid insurance plans. And some commercial plans have sort of actually pulled back their coverage a little bit. And so the question is sort of, do we see insurance coverage like, improving in those areas, or are we going to have to sort of identify these other sort of comorbidities to get insurance coverage? So it's a really good question. So we actually have seen, Zepbound actually get that FDA approval and start to be approved under Medicare for obstructive sleep apnea. So in clinical practice, I think we've had a few patients kind of use it for that indication. Semaglutide also now has that indication for kidney disease in diabetes, but sort of not without diabetes. I think, the insurance has gone back and forth. There's obviously like so much changing with government and healthcare. I would have said like a few months ago, I think like this is going to sort of, progress and more will be approved for just obesity. But there seems to be now some resistance that I feel like a few years from now, that will be the case as sort of more is understood, more is appreciated about the sort of beneficial long-term effects. But I think I don't know, I think it's an open question. Do you guys have anything to add? Yeah. Sure.
I can add the cynic's perspective, which is that, while evidence-based medicine is all important to us, money makes the world go around. And, I think brings me to my next point, which is that as physicians and future physicians in the room, we really have a great sort of experience to advocate for change and to try to improve coverage sort of based on via legislation, because I don't really see it working out financially. So other tools like policy may be really where we need to go.
If I can just add one quick thing. So we know that this is actively contributing to huge health disparities, right? We know our patients who are coming in with obesity are not able to access GLP-1 medications, which have a huge impact in all of their health conditions, while patients who have private insurance can, and that's not acceptable. And I think as so many of you are trainees and thinking about your future careers, and so many of you are research oriented, thank goodness, right? Can we kind of jumping on what Cary was saying, is there a way that we can prove access to GLP-1s lowers healthcare costs down the line by preventing and limiting all of these outcomes, right? And if we can prove that, we can show the financial benefit of it, is that then something that we can advocate for major change on a structural level? So I just wanted to throw that into, because I think that disparity drives me insane every day, and the unfairness of it is just like too much to sit with.
Next set of talks. Thank you so much. I love this turnout. This is really exciting. Yeah, I think the pharmacoeconomic analysis is something I'll bet you that over time it will show a favor towards the drugs and that they can be cost effective. But a different question I have is in your preparation for this talk, trying to understand sort of the mechanism of how these drugs work from a anti-inflammatory perspective. Do you think it's the weight loss itself can be pro-inflammatory? The different kinds and that whole piece. I think it's the drug itself. You've mentioned some inhibition of pro-fibrotic and pro-inflammatory mediators. So I'm not sure what you came across in the literature as some mechanisms there.
Sure. The question was about potential mechanisms for some of these, outcomes that we're finding. Is it weight loss alone, or is it some of the anti-inflammatory properties either independent of the weight loss or related to the weight loss? I'd say that the jury's probably out. There are some researchers that probably have stronger opinions than others. Every time another headline comes through, I think to myself, what doesn't the GLP-1 do? I thought about this specifically when I think I texted it to my colleagues one day a while ago when one of these like Journal Watch whatever emails went out, and it was like GLP-1s help with asthma, and I was like, come on, really? Everything. So I personally have to think that the weight loss and the associated anti-inflammatory effects, in some cases, like for osteoarthritis, the mechanics really is probably the root. But then when we think about obesity medicine and weight loss in general, it's incredibly complicated. It's a different recipe for every single patient. It's not quite as simple as calories in, calories out, and all this other stuff. So I don't have a good answer for you, other than I think the weight loss is the root, but that weight loss is complicated and looks a little different in individuals. If my colleagues have any other comments, feel free.
OA had the least effect between placebo. So, and I think there's this is for that. So the question about the one is that in OA, 30% of the people on placebo across the board. But also there's a dark side to GLP-1 agonist. What about the muscle loss? Because for knee-OA, strength of the knee stabilizing muscles tends to be just as important, if not more important, than just unloading the joint. So any comments about muscle loss?
So the question was about, if I'm summarizing correctly, thinking about less of an improvement maybe in the OA outcomes, and also noticing like a significant improvement in outcomes even in the placebo group. And is there what kind of commenting on the sarcopenia? So I think starting with the second question, I think sarcopenia and muscle loss recently has gotten a lot of attention in the media. And I think there has been a push towards from my understanding, two things. So thinking about prioritizing protein and strengthening, right, as kind of an adjunct to starting patients on GLP-1s. I think there is also, maybe one of you know, there's like another study looking at a newer one. I think it's a triple combination or like a GLP-1 with another combination that's supposed to limit muscle loss in patients who are starting on a GLP-1. So I think that is something that's being looked at, and I think that's really important. And the other thing in terms of improvement in the placebo group, that group also was getting diet and nutrition counseling, which we know does have an effect, maybe not as big. That's true. Mm-hmm. Maybe, or they're just desperate for help. Yeah. I don't know if that fully answered the question, but yeah, thank you.
I don't see any further questions. So again, thank you to our 4 wonderful speakers, and we really love this attendance at Grand Round. So thank you very much.